Today I want to highlight a clinically useful paper on Candida infective endocarditis, a rare but very high-risk infection where treatment decisions are often guided more by limited observational data than by robust comparative trials. This Swedish nationwide cohort analyzed 38 patients with 51 episodes of Candida endocarditis over more than 2 decades and compared outcomes with echinocandin-based therapy, amphotericin B-based therapy, and azole-based regimens. The primary endpoint was treatment failure, defined as in-hospital mortality or relapse. The main take-home point is this: echinocandin-based therapy performed similarly to amphotericin B-based therapy. Treatment failure occurred in 32% of echinocandin episodes, 38% of amphotericin B episodes, and 62% of azole episodes. 1-year mortality from index hospitalization was 26% overall, with no statistically significant difference between echinocandins and amphotericin B. Importantly, the echinocandin group was actually older and had a higher comorbidity burden, so the absence of worse outcomes is clinically meaningful. For daily practice, that means an echinocandin is a very reasonable backbone option, especially when you are worried about renal toxicity, frailty, or tolerance issues with amphotericin. In this cohort, amphotericin B had to be reduced or stopped because of renal deterioration in 11 episodes, whereas discontinuation for adverse effects was not observed with echinocandins. So if you are managing a medically complex patient with Candida endocarditis, this paper supports the idea that choosing an echinocandin is not necessarily a compromise in efficacy, particularly for non-paracellosis Candida. A second major clinical point is that azole-heavy strategies looked worse, even though the study was too small to prove superiority statistically. Azole backbone therapy had the highest failure rate, and the broader message fits what we know biologically. Candida endocarditis behaves like a biofilm-associated infection, so agents with better biofilm activity, namely echinocandins and lipid amphotericin B, make more sense as initial definitive therapy. I would not look at this study and walk away feeling comfortable with azole monotherapy up front, unless there were very specific circumstances. The third point is species matter. Candida paracellosis appears to be a special problem. In this cohort, it was not treated with echinocandin backbone therapy, reflecting long-standing concern about reduced echinocandin activity in serious paracellosis infection. The paper also reinforces that management is not just about the drug choice, source control still matters. About 41% underwent valve surgery, all device-related cases had extraction, and many patients required chronic suppressive therapy, usually with an azole after initial control. So my bottom line is this: in Candida endocarditis, echinocandins appear comparable to amphotericin B-based regimens with a better tolerability profile. Azole monotherapy should make you uneasy as initial treatment. Candida paracellosis deserves extra caution, and successful management still hinges on multidisciplinary care, source control, prolonged therapy, and often suppression. This is not definitive evidence, but it is highly relevant to real-world bedside decision-making.